Well, thank you guys for coming in person. So I'm Christine Gold. I'm a pediatric hospitalist, and I work primarily in the nursery here at University Hospital. Starting to do more work with Chosen, and I work with the policy analysis work group for Support Colorado.
My name is Lyle, formerly Holmes. I'm now Wagner is my last name. And I'm a pediatric nurse practitioner. I also primarily work at the University of Colorado Hospital Newborn Nursery and all the other same things as Christine, starting to do more work with Chosen and also work with the Support Colorado Policy Analysis Work Group.
So our goal for doing this workshop today was just, we have been practicing based on tradition, I suppose, with toxicology testing in birthing facilities for a long time. And I think it's been until recently where people have started to really examine why we're doing the things we're doing, how well they're actually predicting the things we think they're predicting. And ultimately, we want to make sure we go through the baseline of what we've been doing to explain why we decided to adopt new best practice guidelines for toxicology testing, and then try to figure out how we can encourage people who are listening to this workshop and seeing this document to go back to your home institutions, come on in, and start to enable some of these changes that make sense for your organization.
Did you already confirm with folks can hear you?
We did
with the last one.
Okay,
maybe I'm being overly optimistic.
No, that's only 24.
Thank you for joining this hour.
Yes, of course. Almost.
Okay, so we want to be clear that we recognize that substance use, as we talked about all day today, is a common diagnosis in our patients in birthing facilities. And we know that it's not always felt to be easy to identify which families are affected by substance use and which ones are not. And I think that's where people have become overly reliant on toxicology testing, but there actually are many other tools in terms of identifying and wrapping support around families affected by substance use. When we talk about the new guidelines we published from Support Colorado on toxicology testing, we are surprised that every single day people still do not realize that this law changed back in 2020 that actually struck out the text referencing testing positive for a substance as part of the child abuse and neglect definition. And so even though you guys here probably know this, we meet people every day who don't know that this changed. And so we want to make sure we're clear that that was something that changed before we issued these new guidelines. So current state, what's been our traditional approach in our toxicology testing? Well, we know that we're supposed to be verbally or written screening questions of our patients. Whether or not that's happening varies depending on the institution. But the toxicology testing has been sort of used as this gold standard holy grail of identifying who's affected by substance use. And we know from just being in our own health system and also at different sites that our group covers that the application of toxicology testing criteria, the way that the tests are obtained, the results are interpreted, all vary greatly. And that really contributes to a lot of inequity in the way our patients experience our healthcare when we are testing them. We don't believe that the evidence as currently published really shows any gold standard evidence-based criteria for toxicology testing, though there are common criteria used across the country. We also acknowledge that some people say, well, if there's certain criteria versus others that are less equitable, maybe we should just test everybody. But no major medical organization recommends universal testing as an alternative. And we know that the way the test results are utilized and reported to CPS remain inequitable. So we don't think that that's also a good alternative at this time. So the risk-based criteria I'm referring to, we're talking about selective criteria such as late prenatal care or history of interpartner violence that is prompting toxicology testing, whether or not there's any other concerns that this family may or may not be impacted by substance use. And the guidelines we published this year really try to emphasize that in general behaviors are more important than selective indicators of risk when we're talking about toxicology testing. Steph Bork was actually our last workshop group we just did, and she did a great talk at the CPCQC meeting this spring about some of the evidence for what criteria we use at all these different hospitals and birthing facilities. And actually, a lot of criteria isn't very well supported by the literature. We have not been published yet, but we looked at our own population that's been tested for toxicology for substance use, and we found that late prenatal care was not associated with a positive test result. It was actually associated with a negative test result. And our whole cohort of 534 charts we reviewed, 18% had a language barrier, but in the late prenatal care group, 67% had a language barrier. So we were not only not identifying substance use, but we were disproportionately selecting for our non-English speaking families. And that's something I think we're going to see more and more in the literature. So we can do better. But when we talk about these new guidelines that we published this year with Support Colorado, it didn't happen in isolation. And this is the best kind of quick timeline I could put together, but the groundwork has been laid for years on doing better to support our families affected by substance use. We have all these different organizations that have been formed. We have different legislation that's occurred, including saying that you cannot criminally prosecute someone in pregnancy for divulging their substance use, trying to add more resources to support these families. And then in 2020, the act that struck the positive test from the language in terms of child abuse and neglect. So in 2021, we were put in touch with the Support Colorado Policy Analysis Work Group. And we said, listen, this toxicology testing criteria and practice is all over the place in the institutions we cover. And if anyone's going to take on really trying to issue a best practice guidance, it should be the Policy Analysis Work Group for Support Colorado. So we tasked the group with that in 2021, and it took 2 years of working on this many times a month with many different people all over the state. And what we have produced is best practice guidance for indications in toxicology testing in birthing facilities. And we hope by the end of this, we empower you guys to want to take this work even further. So I'll turn it over to Lyle.
All right. So Dr. Gold's done a great job. We've established a lot of background. From here on, we're going to review some definitions and common terms that we hope you will use when you're talking about these subjects. We're going to look at the current toxicology testing criteria and variation in practice and how they contribute to inequities and bias in care. And then we'll review those new toxicology testing guidelines, and we want to work through a case to help identify how toxicology testing impacts the care of both the birthing person and the newborn, and then hopefully reflect and identify areas for improvement at our institutions. So common terms and definitions, I won't read all of them, but the one that we spend a lot of time trying to highlight is this difference between screening and testing. I think we all know that these terms are often used interchangeably, but they're really referring to two different things. So when we talk about screening, we're talking about the process of gathering more information from a patient about substance use through the use of a validated screening tool. Testing, on the other hand, is talking about using a biological sample to assess for the presence of a substance and/or its metabolite. So we spend a lot of time correcting and focusing on the differences between these terms, and think it's really important for anybody working in this space to really distinguish between these two ideas. For the purposes of this presentation, we fully endorse and support that screening should be happening universally, but we're going to focus on toxicology testing. The other one that I wanted to highlight is bias. So bias, or we've been talking a lot about stigma today. Bias is the prejudice in favor of or against a thing, person, or group compared with another. And we want to recognize that when we're talking about bias, we aren't just talking about intentional or explicit bias, which it often is with this patient population, but we're also talking about implicit bias. And when we're talking about these risk-based traditional toxicology testing practices, there's a lot of unintentional bias that goes into it. So these are common examples of selective or risk-based criteria that you guys have probably seen, spanning everything from adequacy of prenatal care, social factors, issues, medical issues with the birthing person and/or newborn, and I'm sure that these show up in your home institution policies.
basically doing ours.
Yes, for sure. Okay, so since we have a small group here, if it's okay to just do like an informal discussion, that would be great. But we really want everyone who thinks about our new guidance to reflect on how current state at one's own institution might be promoting practices that lead to inequity in the way we care for our families affected by substance use. And so, Susan, we know each other well, but I think, were you presenting earlier today too? Okay, so you're looking to get into more clinical work, and good luck with your application.
Thank you.
And then do you work at Denver Health? Is that right?
No, so I work at Lutheran.
Lutheran, that's right, that's right. So I think you guys do have a policy as well for toxicology testing.
We actually have a new one that's about to go live that takes all these recommendations into play.
That's amazing.
It really is nice.
That's great.
Actually, yeah.
So when we think about the selected criteria we just reviewed, I mean, definitely probably some of the sites you cover, I think those are still present and maybe in your current iteration that's about to change, but I'm guessing some of those selective indicators of risk are in that policy. Would that be accurate?
Yeah, and the nice thing is that it's system-wide, and it's taken a while. It's taken about 6 months to get this fully finalized because it's a lot of hospitals that came together to get this to be standardized across all of our system.
That's awesome.
6 months is amazing.
Yeah, 6 months.
Super short
Yeah.
for a whole season. I was like, wow, we're 2 years in and we still don't have much.
Yeah. Well, and that's so for our institution at UC Health, you know, we've been working on this at a system level for well over a year, and we're trying to partner with Children's, and it's uphill. It doesn't mean it's impossible, but it takes time. And so, yeah, 6 months sounds amazing compared to
Off a little bit, but
but I know what you mean. But you know, actively, we still show up to work every day with a policy that has a lot of those selective criteria. And so we're constantly asking ourselves, like, we're contributing to this bias and inequity by enacting these policies, but it isn't a policy, but getting the buy-in to, you know, getting universal promotion of what we're trying to change is very hard. Have any of you ever looked at, like with your home institution, how well your verbal screening versus your biological toxicology testing identifies substance use? Have you ever looked at that?
I don't know that we have. We now have the opportunity where we could. So we participated in the Colorado SUD AIM project, and that's what fostered a lot of this work. And we have now a new social determinants of health verbal screen that's done. And actually it's one of the things that when I do the data collection for Chosen, I can go back and compare that to see how the verbal correlates with actual tests or screening and then testing if needed, and how that's done.
And it's actually been kind of hard, even just getting those verbal screeners and the cost. I'm with CPCTC, and we're getting, some hospitals are on it with the screeners. Not all hospitals are on it with the screeners. Luckily, some of the larger medical systems are the ones that are quite good at it. But even just getting the verbal or written substance use screener is like an uphill battle, trying to get it in the hospitals.
Well, for us even, so I think we're a site that's participating in the same Colorado IMSED bundle. And what we find is when we're on, even as recently as this week when I was on service, you can go in and see that someone marked as reviewed the substance use screener, but when you go back and do the audit trail, you can see it hasn't been updated since maybe the first OB intake. And so we think like, wow, if we maximized the verbal screening, how much information would we additionally obtain with the testing? But we're not even there yet. And so we just want people to think about, you know, sure, you're relying on testing so heavily, but what are the other things that could be maximized that would actually make a difference? We've been pretty clear on how some of these criteria are contributing to inequity and bias. What about, have any of you looked at your institution's data just in terms of the criteria that have prompted testing and how well it's correlated to your actual results? Has anyone else, like we did at our institution, but did you ever look at that?
I don't think we've looked at it yet,
Okay.
but we certainly can.
Yeah, it just would be interesting. I don't know, Susan, if there's sites that we work with otherwise that looked at their data.
I don't think we've looked at that data, and I'm not sure we collect that, at least even amongst the Chosen facilities, facilities. You can imagine what sort of data digging that's going to take.
Yes.
Yeah.
It's a lot of work, but as we've tried to adopt some of these new guidance recommendations at our institutions, we found that asking and posing some of these questions to people who are not certain about changing our current practice has been helpful, because actually most people are clinging on to an idea of what they think is happening, but sometimes the data doesn't support it. And so us asking these questions here, we also hope maybe some of these will be good tools in bringing these conversations to your institutions.
The other point that I'll make is that even if you think your hospital has a policy or guideline, you're just one person in that sort of entity that you may know it and others may not. So you might have a policy or guideline, and how it's actually implemented and operationalized and disseminated is a whole nother issue. And the evidence around that is, as I mentioned with the systems level survey, one of the reasons that I didn't present the one that we did in April is that multiple providers from the same institution gave different answers around systems level questions around, does your hospital have a toxicology guideline? Do you do plans of safe care? Yes, no, within the same institution. So yes,
Yes,
That's
it's highly
Really good
variable.
point.
Yeah, even with those structures in place, if there's not any sort of circling back to see how people are using it, yeah, so much variability all over the place. And that's what we wanted to emphasize with those questions.
So that leads us to the product that came out of the Support Colorado Policy Analysis Work Group, which is the indications for toxicology testing at Colorado birthing facilities. And I think you guys have all seen this document. It's linked at the end, but as Christine said, this was really the product of us coming to this group saying this has to happen. There's so much variability, both within our own institution, around at different birthing facilities around the state, and isn't there somebody who can help create a guideline to help create some consistency in care and improve that care for both birthing people and newborns affected by substance use. So here, that's the document. We'll link. As far as what it is, we won't go through all the details, but I think what you will notice is that there's a significantly slimmed down list of criteria for testing, and it doesn't include any of those risk-based criteria that we've already talked about are not evidence-based. The guideline really focuses on testing indications, thinking about how that test result is going to be helpful, but also considering how it could be harmful, both for the birthing person and for the entire family. The other thing that we'll talk about in more detail is that it emphasizes the importance of obtaining consent, not just for the birthing person, which is more commonly done, but also for the newborn. Other just components of the document include the importance of trauma-informed care, as well as working as a multidisciplinary team when we're caring for both birthing people and newborns, that there's a lot of different people at the table, and that idea of the plan of safe care and resource identification, which you guys have heard a lot about already now. So we want to walk through a little case. I'll go ahead and read it, but you guys can read along. It says, so we have Angela, who's a 27-year-old G1, P1, or P0 birthing person who presents to your birthing facility in active labor at 39 weeks with vaginal bleeding, appearing agitated. She reports that she had prenatal care at an outside facility. Records have been requested, but not yet obtained. She denies any pregnancy complications, but does report a history of methamphetamine use until 22 weeks, at which point she stopped, and she denies any other substance use. Her only medication during pregnancy was a prenatal vitamin. She does have a history of homelessness, but also reports that she now has stable housing, and the father of her child is not involved. So again, since we have a small group, wanted to think about these questions and either based on, I guess let's go based on the birthing facilities that you may work at. We can probably see a lot of reasons that toxicology testing would be indicated on Angela based on this traditional risk-based criteria. So I know that at our institution, toxicology testing would be indicated. That similar to how it would present at y'all's birthing facilities.
Oh yeah, this mom would get her like admission labs and a urine tox
Yes.
screen
Yeah.
without any discussion.
Yeah. So multiple things here, right? Like she's telling us she used substances. She has vaginal bleeding, so we're thinking, is there a placental abruption, which is criteria in a lot of places? She has a history of homelessness. What else? There are a lot of things.
You're agitated.
Agitated. So when we think about like, how would this testing be helpful? Well, she told us that she's using meth, but she said she stops. So testing Angela might be helpful to tell us whether or not she's being truthful, right? Did she actually stop or is she still using?
Does baby have any concerns, or is baby still in at this point?
Once born, no, there's no concerns. Yeah. I agree with that.
That's, I can
That's a
think
good
of that
question.
being a reason, but other than that, I've got none for you.
Based on the case at the birthing facilities that you all work at, it's primarily you too, would the birthing facility or the provider obtain consent before testing Angela?
Depends
Do you
on who's
know?
on.
Yes, good answer.
If it's someone who's a little further along on their, equity with SUD journey, I suspect there would be a very inclusive conversation that occurs versus perhaps someone who hasn't engaged in these discussions for the past 10 years. I suspect they would just go ahead.
I feel the same way.
Yeah.
Yeah.
Some would have a discussion, others would just tell the nurse to get a urine sample and do it.
Yeah.
Yeah.
And would, based on current criteria or traditional criteria, the infant would also be tested, right, in most of our birthing facilities.
Yeah.
And how would that, do we think about how that would be helpful? We talk a lot about, usually we use umbilical cord toxicology testing and how that takes, typically usually more like 4 days to get the result back. So how is that test actually helpful to caring for that infant?
I mean, I think the premise there is still this lack of trust, right? That we think that we're gonna test just in case there's something that we're missing. And for the infant side, we know there's not a meth withdrawal, but
Right.
maybe there was fentanyl, maybe there was some
Right.
other opiate. And so if there's potential for withdrawal, then that infant's hospitalization, may be longer based on, best guidance from the AAP. But I think what underlies that is still this unease, like this what if scenario.
What if, we don't know exactly all that this baby was exposed to.
Yeah.
Even though, let's say we didn't do it on the baby and they're showing withdrawal at 36 hours, we're still gonna treat that if they need it,
Exactly.
even without knowing that result.
Can I say something too? So we often see this where we end up doing an umbilical cord tissue sample. It does come back maybe before they leave, maybe before or after they've left. And it's still positive for methamphetamines, which actually works out when you figure out the timeline of their use, doesn't tell you they stopped or not. And it can also be positive for fentanyl, but there's a lot of contamination of methamphetamine in Denver with fentanyl. So it doesn't tell you if they knowingly ingested it or not. And we give fentanyl in labor a lot. And so it's also often timed that we did the cord after we gave the fentanyl. So when you really start to think about how helpful it is or not, there's a lot of nuance to it, right? And that's what we struggle with exact cases like Angela's all the time.
Yeah. Go
I
ahead.
think the other part of it is, I think more on the maternal side, well, perhaps if the baby also, on the ped side too, I shouldn't just defer to the OB side, but it's work, right? To engage, it's meaningful work, but it's work to engage with the birthing individual, to gain trust, to ask those screening questions and elicit an answer, right? And to trust that response versus in a busy L&D or even in a busy NICU, you just send the tox screen and it's yes, no. There isn't this establishment of an emotional connection, right? So I think for many of us in healthcare, the screening part still is hard, whereas the toxicology part is a lot easier to do.
It's a good point.
Yeah.
At Lutheran, do you all obtain consent before
So
testing the
we
newborn?
actually had not up until recently.
Okay.
If we found a reason to test the infant, we could tell the mom, we would tell the mom we were going to do it, but she couldn't say no. She could, but we still would do it. And now we are obtaining consent.
How common is it that either mom for mom's own testing or mom for baby's testing denies? Yeah, like how prevalent is that? That they say
Not as common as people worry it would be.
Really?
Exactly.
We've always done consent for newborn testing at our site, and I kept a list of it just to see, out of curiosity, and of all the tests we do every single month, maybe 1 to 2 will say no on the newborn, and
Wow.
it's not as many as you think, so.
And that number has, I would also, yeah, never mind.
No, it's okay.
All right, so my next question for you is, did you guys have other questions for Angela? So I gave you this pretty typical report that is passed along through care providers, both on the labor and delivery and towards the pediatric provider side, but did you have other questions for Angela? And yes, Dr. Wong, fully acknowledge that people don't want to engage in these conversations, but really that's best care, right? That's how we identify who needs what. So I'm curious, what other questions did you guys have? Did you want to consult other care team members or other services? Would you have made a report to Child Protective Services based solely on what we heard?
Follow the CPCQC recommendations. I think the appropriate, or at least a few of the appropriate next questions would be like, have you received education on this before? Have you received naloxone? Do you want to consult to addiction medicine? Can we schedule your postpartum appointment? That's all that's coming to mind right now. But like, there's some pretty solid follow-ups of like, who is taking care of you, and how can I facilitate that?
Yeah,
Which
I
also is
also
hard.
would want to know more about the use of the methamphetamines, because to me, it's a little bit interesting when they just stopped at 22 weeks. Like, what prompted that? Is that really what's happening?
Mhm.
What's going on are there factors in place that you actually aren't, I wouldn't say this to the mom, like, put it differently, like you aren't being truthful or what I would, but again, it takes time to develop that rapport to get to know if that's really the story or if there's more or whatnot, because then that might guide what else I would provide for this mom. Because I also think maybe she did stop and maybe she's done some rehabilitative treatment and she's not disclosing that. And then for us to throw all these services at her, we're just assuming she still has a problem. I mean, that's the other thing too.
And if I may, I think somewhat reframing that from my perspective is around like, how are you being supported in your recovery?
Yes.
Because I think that there is that, first of all, like a lot of parents might have a lot of motivation around, I don't want my, child to be impacted by this, physically. And also new parenthood is so stressful. I mean, the lack of sleep, I can think about how many triggers would exist for new parents who have experienced that addiction. So I'm thinking a lot about, does recovery support need to look different? Do you have childcare so that you can continue receiving your treatment services? So I'm thinking a lot about some of those factors. So yeah.
Great point. Yeah, I mean, I think it sort of gets to the plans of safe care, right? What do we have in place? What have we created that optimizes, the likelihood of success with ongoing supports and services? We're just in the cannabis one next door. And, I think to the point that was made earlier during the session, like the substance use is sort of the end point, right? It's the outcome that we measure and that we perseverate on, but what are all the things? And, postpartum, first, month to the first year postpartum until the end is such a difficult time. And so I think that the making a report to child welfare, I think in the healthcare field, especially on the newborn side, was such a hard one to still even grapple with, because even this notion of plans of safe care, is this a safe discharge? The question is, are you leaving it up to me as the birth hospitalization provider to decide that this baby is safe to go home? Like, what does that mean? Like, what is my responsibility in that as a healthcare provider? I think that's what people are still trying to grapple with, like that somehow it's up to that particular provider to like give the blessing, this child is safe and can go home, and God forbid something happens, right? And so this idea of safety or well-being, I think is what's real hard at the birth hospitalization time, because it's so brief. to conclude that, well, we think the baby is safe enough to go home. And even that phrase sounds awful, but
No, it's
Yeah.
true. We wrestle with that every day.
I have a question about that is partially on my end and partially because I've had a few people ask me and I don't totally have an answer for it. So with the known biases in tox testing that have existed where certain groups are getting overrepresentatively tested. From my understanding, the pattern used to be that if you had a positive, that there's inequity in who gets tested, but if you have a positive tox, it goes to CPS. And now my understanding is that there is provider decision when it comes to who gets tested, and then of those who test positive, like you mentioned, it's provider discretion of who then gets reported. And I've had a couple of people ask, like, won't that exacerbate the issue? Because if they can look at like white or higher socioeconomic status families with the same positive tox and be like, oh, I'm sure this kid's fine, whatever. So how, like, I just don't know, I never know how to answer that question, because I know the intent is to decrease this inequity, but people are saying that it might increase it, and I would love someone's opinion who knows more than me.
I think if I were to try to answer that, so
Yeah.
like, I think that the fear is that, okay, well, then we're gonna start to use our own biases again to decide who's chosen and who's not. Whereas I think the conversations we've been a part of are like, well, a positive test doesn't mean actively using child affected by and threatened by.
Right.
So what are the supports in the family? A lot of core tests could be positive and someone could have stopped using, and did they have care? Like, basically multidisciplinary conversations are really important. Talking to the person who's provided prenatal care, who's provided addiction medicine care, what kind of, maybe they've had testing that's proven they've achieved sobriety, they have these supports in place, we have appointments for them after. What is CPS going to add? There's a lot of things of resource assessment, support and engagement that will really determine. And I think that feels somewhat objective, and we try to follow that plan of safe care framework pretty closely. It's when we don't think that we, have a safe plan going forward in terms of ongoing engagement and care. We've seen behaviors in the hospital that make us more concerned that we report. I don't know if that's actually a good answer now, but I think.
Well, the other thing that I would point out is that, and I will be one to say that I used to feel this way. We had this very strict set of these guidelines, and I was applying them equitably to every single person. And we realized that they were implicitly biased, right? Because we found that we were actually disproportionately selecting for people. So they were then disproportionately being tested. We know that people, at the end of the day, who's making our child a report to CPS is still an individual calling and making that report. And we know based on the data that even positive tests or allegations of child abuse and neglect are disproportionately affect marginalized populations. And then we also know that CPS responds differently even before we changed all this. So I would say it's already happening.
Yeah.
And yes, those conversations, that still needs to change, but for all the things that Christine is talking about, like trying to identify those objective things to help identify how we're acting on individual situations as opposed to applying these blanket rules.
And that would be in a situation, unlike what you had mentioned, where it kind of depends, like if the baby gets tox tested, depends on which provider's on call that night, like how far they are in their journey. Is this as dependent on the provider, like intention to complete all this, or is it?
I can weigh in and say, I mean, there's a lot of discussions in the child welfare space to come up with some sort of criteria, right? What are some criteria for reporting that birth hospitalizations can use, right? So if you recall, even like 5 years ago, there's cannabis use. Those were reported. Well, child welfare is like, I don't want to hear about all the cannabis use. We don't have the bandwidth to investigate all of it, right? So it really is about being threatened. So the child well-being, and I would say we use safe provider, and I guess oftentimes I think of medical provider, but it's our social workers who are really in it, right? Who are assessing family support, family follow-up in the long run, and already established engagement that exists with both health and behavioral health services. but it is an active kind of area that people are working on. Can you come up with some sort of criteria where birth hospital folks know, oh, here's a checklist, and then we're gonna, now we can call. One example that I'll give most recently is, I was attending a children's hospital, and there was an infant who's been there for a long time, was a former preemie with lots of different issues, and the mom was in recovery, and she was on methadone and actively in a program. And I feel like 10 years ago, that case would have still been reported to child welfare, that none of the medical providers would have felt comfortable saying, I'm confident that this baby is safe to go home with this family. But this time around, it was awesome. The social worker came, heard that the mom was already engaged in treatment. She called the treatment center. They had great conversations back and forth. There was exchange with obviously maternal consent of her treatment history and continued engagement. She also was at the bedside, clearly demonstrating how she was so engaged with the care of this infant. She had supports at home. Social work never called child welfare. We as a team felt that the safety of this baby felt very much insured. Awesome. And it was just a very different approach than what would have happened 10 years ago.
Totally agree. I think that threatened piece is really crucial. At first we were like, this is so vague. Like, how are we gonna determine affected and threatened by? But then we realized the same thing. Maybe your baby withdraws because they were exposed to methadone, but they don't have an ongoing threat to their safety. Yeah. Like it's actually helped. And to your point, bias will exist to some extent no matter what we do, but testing disproportionately impacts that. And so if we can improve that piece, hopefully we can improve the other pieces. That's a great comment to make.
Okay, I love this discussion. I want to wrap up this case real fast because I think this is going to hit a lot of the things that you guys were talking about. But so you find out after you ask more questions, which were all great questions, or somebody spends time actually talking to Angela, you learn that she was actually living with a boyfriend who was verbally and physically abusive. She finally decided to leave him, ended up moving in with a friend, but then that friend had an ill family member that forced Angela to move out, and she ended up on the streets. While she was homeless, she met somebody else who introduced her to meth, telling her that it would not only help her feel better, but also keep her more alert and safe while she was living on the streets. Angela then actually found out that she was pregnant at 22 weeks and immediately stopped using, worried about what it would do to her unborn child. She established some prenatal care, and it was that OB provider who connected her with the clinic social worker who got her into a homeless shelter and eventually helped her secure housing. She also connected to a community group for women with substance use and found a peer recovery coach who she identifies as her primary support throughout this pregnancy. She had consistent prenatal care after she established with that outside facility, and still has that peer recovery coach who she identifies as support, but also has a mother who lives out of state who is planning to come help her once the baby arrives. So I think we've all identified that these are the questions that we actually need to be asking is what supports do you have? What do you need? What do you not need? And how do we wrap this stuff around our families?
Okay, so with the issue of consent, I just want to bring this out one more time, is that we've had some pushback since we issued our guidance in April about the idea of consenting for newborn toxicology testing. And again, we've always done it at our site, but we recognize a lot of sites have not done it. When you think about Colorado, there's a lot of authority in parenting, making decisions. We do a lot of consent for everything else we do for the newborns. Why shouldn't we do it for the newborn toxicology testing? And it really does provide an opportunity to have more of these conversations with families and also be very upfront about the impacts of this testing, not just to the medical care, but also to the disposition planning and follow-up planning. And so there is the potential, as we have people read our guidance, that there will be some pushback on this at your own institutions, but that we really do think this is best practice. And we heard earlier today, there's even some legislation that may or may not make it forward, but that will be promoting consent for both birthing person and newborn toxicology testing. So what are our takeaways from this workshop? Well, we have been doing things traditionally for a long time that aren't evidence-based and really don't best support our families, and we can do better. The toxicology test is one piece of the puzzle, but there's so much else to do to help take care of these families. And each patient's different, so it's not a one size fits all. Individualized care is really important, and we recognize that with our guidance, each institution is a little bit different as well, and the uptake of best practices will be different. And so we want to make sure that people realize our guidance that we issued is not meant to be overly prescriptive. It's not a policy to just plug and play, but it's meant to prompt conversations about how can we do things differently and change our approach so that we better care for our families when it comes to toxicology testing. We think that we all agreed by the way we went through these cases that current state's highly variable, actually not required by law, which is a common thing you'll hear in rebuke to this guidance, fraught with potential harms, consequences, biases, and really not well supported by evidence. And so we hope anyone who's listening to this workshop today will feel empowered to read through the guidelines if you haven't, and figure out who are key players at your own institutions to have these conversations, work through improvements in toxicology testing approaches, and better care for our families. And we just thank everyone who's already here, because without your engagement in caring for these families, none of it would be possible. And there's a lot of resources. So this QR code links to our guidance on toxicology testing practices through Chosen, Colorado Tox Guide, my email, Lyle's email. We will respond to any email from anyone who's interested in this work, because we've been doing it ourselves for a long time, and we are happy to serve as a resource. And that's the end. So thank you for joining us in this conversation.
That was awesome. Thank you.
Thank you. Thank you to everyone on Zoom as well.
So how close do you think you are to going live with this kind of new version across university system?
So we're hoping soon. We've talked about this offline, that there's a few people who are still very against this, that Memorial, or I think it was the Memorial system, just tried to put forth what we recommended as the guidance, and it got shot down by the same people. So trying to clarify, do we need 100% buy-in? Like, what do we need? But we're hoping within the order of magnitudes of months that we'll get this finished at UC Health. And we've identified a couple other maybe executive sponsors that might help just push this through. So hopefully that will happen at UC Health, and hopefully we'll keep partnering with Children's to make these changes.
Thank you.
Yeah, thank you. And I'd be really interested to see what Lutheran has that they're about to put through.
Yeah, absolutely.
They're willing to
Actually,
share.
I asked for a copy, but I was told I couldn't share it just yet.
Okay.
When does it
boy.
share? Yeah, we would love to see
Read
it.
through it.
Right.
Well, if you guys want to go back up to the main area, there's gonna be some nice dessert from the D-Bar.
Oh,
Yes.
from D-Bar?
D-Bar, yes. Every time we have the Chosen Forum, we have like little cupcakes and little macaroons with the Chosen
Logos.
logo on it.
I remember
It's quite amazing.
That sounds amazing. Okay.
Yes.
I'm sold. Thank you guys. I appreciate it.
Thank you.
But I'm Susan Wong.
I'm a policy manager with the Women Make Policy.
Great.
Thank you as well.